The sound waves from this video are vibrating your eardrum and ear bones, which is vibrating fluid in here, the cochlear. This is the heart of your hearing. The fluid moves little hairs which stimulate nerves called spiral ganglion. These send the incoming vibrations to your brain to process as a sound. But for those with a damaged cochlear, and therefore damaged hearing, a cochlear implant can bypass this and stimulate the nerves directly using electrical impulses, bringing the beauty of sound to the hearing impaired. I'm going to talk about how the body responds to the materials used in these implants, focusing on these 5 key questions. They look like this, with the receiver casing made of strong titanium alloy, and the cochlear stimulating electrodes made of conductive platinum alloy coated in soft silicone for a less traumatic insertion into the cochlea. Before being used in implants, materials need to go through biocompatibility tests. For our cochlear implant, we need to look at cytotoxicity, allergic reactions and chemical reactions with the body. Silicon-based platinum microelectrode arrays pass the cytotoxicity test. The test that's been used for this is called an MTT assay. MTT is a dye that turns purple in the presence of enzymes in living cells. Fibroblasts, which are cells which produce fibres in the body, are easy to use for this as they like to adhere to materials. The less cytotoxic a material is, the more cells will proliferate on it, and so the more purple the solution that's in contact with the test material will be. This can be measured to give a quantitative result for its cytotoxicity. Titanium and platinum also pass this test. A minority of patients have metal hypersensitivity, so may have an allergic reaction to the titanium or the platinum used in the implant. For these patients, some sample material can be inserted subcutaneously to observe whether there's an inflammatory response. However, a more accurate option can be a MELISA assay. This puts the patient's lymphocytes, which is a type of white blood cell, on the material and observes the reaction. The materials used are chemically inert, so won't chemically react with the body's cells and irritate them, and unlike most metals, platinum doesn't produce a corrosive surface layer when a current is passed across it, even when it's charged for 10,000 hours. After passing the individual cell test, also known as in vitro testing, the material has to be tested in a living body, also known as in vivo testing. This is because in living organ systems, cell responses become much more complicated, responding dynamically and communicating with each other using substances called cytokines. This means the tests have to be done on live animals, often guinea pigs. Cochlear implants pass the guinea pig test sufficiently, but living organisms are complex, and like with all implants, there are more challenges that emerge. Inserting any material into the body is going to elicit a foreign body response. Firstly, the surgery to implant the electrode cuts through muscle and bone. These wounds are going to bleed a lot, so your body needs to seal these up fast. The blood contains lots of cells called platelets. Their job is to detect the bare collagen from split blood vessels with their integrins in their cell membrane. They're going to come together and clot anywhere they detect this bare collagen and start clotting the wound. All cell processes, both inside the cell to make it do anything and between cells to make them work together, are mediated by cytokines, which are often proteins. In the case of platelets, the signalling pathway starts with the integrins. They detect the collagen and emit ADP, TXA2 and thrombin. These start a signalling pathway of absorbing and releasing more of them and other cytokines. The membrane of the platelet, like all cells, is covered in receptors. The platelet contains a lot of ion channels. These are small enough to allow ions, such as calcium, to enter and exit the cell, but not let bigger molecules through, and they open up in response to a molecule acting a bit like a key to a gate. This molecule will have come from the signalling pathway that was started after the collagen was detected. The calcium is needed to tell the molecule to change shape and start clotting. How do signalling molecules get across the platelet? Well, it's different depending on the molecule. Sometimes they just casually diffuse through, but sometimes the large ones have to take the microtubule motorway as cargo being pulled by motor proteins. ATP and ADP are important here. They deconstruct and reconstruct the microtubule to move the stuff wherever it needs to go, a bit like the moving staircase in Harry Potter. This pair of molecules are also responsible for moving the motor protein across the microtubule. This motor protein movement is happening in all cells, not just for moving cytokines, but to move nutrients or building blocks across this busy cell. Okay, let's zoom out to the blood again. In order for our platelet to move, this signalling pathway results in the cell remodeling its skeleton, made of actin filaments. Once again, this is an ATP-ADP thing. It reaches out and adheres to the collagen directly using its integrins. On their exposed side, the platelets bind to fibrinogen. a protein in the bloodstream which acts a bit like a glue between the platelets. More platelets come along and adhere to this, having similar intracellular pathways as a result, and a clot forms at the wound. All this commotion releases cytokines outside of the cell too. TGF-beta, for example, which attracts fibroblasts. Remember that their job is to make fibrous tissue. They follow the trail through the bloodstream, called a chemokine gradient, to the wound. And when they're there, they rapidly lay down this fibrous tissue made of collagen for strength, elastin for flexibility, and fibronectin so that new cells can stick to it. This creates an extracellular matrix to reinforce the clot and promote new cell growth. The cell's integrins bind to this RGD peptide group. That's 3 amino acids together: arginine, glycine, and aspartic acid. They feel like the matrix using their integrins to know how to arrange themselves and grow. The tissue is rough and weak at this point, as the fibroblasts have prioritised just covering up the wound, but they'll come back later to reconstruct it to be stronger so cells can grow better. If the wound isn't closed up sufficiently with surgical methods, the rough collagen is seen as a scar on the implant site. So now the immune cells are going to get involved. Mast cells in the tissue aren't happy that they've been displaced, as it tells them that there's a wound, so they start pumping loads of IL-8 and TNF-alpha cytokines into the bloodstream. Macrophages and neutrophils follow this chemokine gradient, which allows them to change shape and slip through the epithelial lining of the blood vessels. This is the body's first line of defense. Their actin filaments can remodel to engulf and enzymatically break down any foreign bodies, such as dead tissue, bacteria and viruses, and also our cochlear implant. At least they're going to try, but our cochlear implant is huge compared to them, so they remained in this inflamed state known as M1, and they get frustrated. That's actually the technical term. They emit interferon gamma and interleukin-1/6 cytokines to communicate to each other that it's time to change strategy, and band together in a foreign body giant cell, which surrounds the implant. They start pumping enzymes into it in an attempt to break it down, and call up the fibroblasts with yet more cytokines. They don't know what this thing is. They can't engulf it, so they're going to try and block it off from the rest of the body. The fibroblasts come along the chemokine gradient to our implant. It's got plasma protein stuck to it by now. There's always loads in the blood. The fibroblasts bind to these and check our implant's mechanical properties by pulling on their integrins. They assess the issue, how many of them are needed, and how many osteoblasts, which are bone makers, are needed too, and how much fibroblast material to create, kicking out cytokines in response. This process is called fibrosis and can range from mild to creating an inflammatory granuloma, which is a big mass of fibrous tissue that has its own blood supply and kicks out a load of cytokines that cause inflammation. In fact, it's a little bit like a tumour, and the inflammation that this granuloma causes can cause other cells surrounding it to become cancerous as well. This term, inflammation, means that in response to the cytokines being produced by immune cells or granulomas, many of the body tissues are undergoing apoptosis, which is a controlled cell death, or in worse cases, necrosis, which is uncontrollable cell death. Experiments injecting mice's toe pads subcutaneously with nitrocellulose showed that interleukin-1 alpha and tumour necrosis factor alpha were produced by macrophage giant body cells in the first 28 days, and after 2 months these were replaced with transforming growth factor beta. These cytokines are all very inflammatory, and they cause fibrosis and granuloma formation in excess. These cytokines are the same ones as released following our cochlear implantation, which shows that anything that's implanted into the body is going to get fibrosis around it, and it's caused by these inflammatory cytokines. If they get really big, granulomas will cause necrosis. One 58-year-old patient's device stopped working after a year. The device was removed and re-implanted, but to no effect. What was strange was the device worked fine when tested electronically. Unfortunately, the patient's cochlea had developed a huge granuloma from the implant, which caused the entire organ to necrotize and hemorrhage. The patient died as a result. While this is a unique case in its extremity, post-mortem analyses of temporal bone tissue show that patients have fibrosis and giant foreign body cells around the implant, especially in those who experienced post-implantation hearing loss. Patients often retain a certain level of hearing, which allows them to utilize the implant most effectively, and in the best cases, they combine their cochlear implant with a standard hearing aid, allowing them to experience a full range of hearing. But the nerve and hair cells within the cochlea are very delicate, and inflammation due to fibrosis can cause a lot of damage and scarring to them, which irreversibly damages this residual hearing. But materials science does offer some solutions, such as changing the surface geometry of the silicone. Some promising research from teams, such as Spatz et al., have shown that laser etching of the surface can alter the silicone's hydrophobicity, preventing fibroblasts from laying down the extracellular matrix required to create focal adhesions with the device and initiate fibrosis. Nanomaterials embedded into the electrode could be used to deliver medicines that can't get to the cochlea otherwise, due to the cochlear-blood barrier. Antioxidants or neurotropics like IGF-1 can support nerve health, and steroids such as dexamethasone can reduce inflammation and prevent fibrosis. While it only occurs in less than 10% of cases, bacterial infection can also cause issues. Gas bubbles from the silicone manufacturing process create microscopic pores of about a couple hundred microns, which support bacteria in production of biofilms that help them adhere to the implant and protect them from the body's immune system. These pores are difficult to control, and if they were a different size, the bacteria would respond differently, but so would the body's immune cells too, so there's an interplay here. But it's not necessarily a good thing just to change it in one direction. You need to consider the holistic view of the implant. The biofilms have an important role to protect themselves from the immune system and lets them propagate massively, releasing toxins causing hearing loss and infections such as meningitis that can spread throughout the body. Here's an image of an infected cochlear implant that had to be removed. Thin film coatings of titanium oxide are theorized to repel these biofilms, while being thin enough to keep the desired soft properties of the silicone underneath. Goldfinger et al. Investigated this using a BCA assay, which is a test a bit like the MTT assay, but measures protein concentration rather than metabolic activity of cells. Here, it was used to measure the concentration of biofilm, and it turns out the titanium oxide coating works. Bacterial adhesion was reduced by 90%. While the coating repels biofilms, it does not kill bacteria. However, nanomaterials may have a solution for this too. Silver nanoparticle coatings are not only antibacterial, but have shown to exhibit anti-inflammatory effects in the body, so they could be used to combat infection and fibrosis. More research will need to be done to confirm this. The science is complicated due to the complexity of the human body, but continuing with material science research and pushing towards the vision of a better implant has a direct impact on people's lives, bringing them freedom and giving them a better quality of life.
Grayson points his finger there, hearing sound for the first time ever. Can you hear that? Yeah.